we will go with the next speaker. So Dr. Amir Kheradmand and Dr. Qadeer Arshad. You guys are doing in sequence, Amir, or you are just transferring over once
Well,
you're
I
done? So
think
I'll just do
each
the
of us,
introduction for both.
sure, we each are going to share our screen, so we're going to take
Okay,
turns.
so I'll just introduce both of you guys together. So please
Sounds good.
allow me to welcome Dr. Amir Kheradmand. He is the assistant professor in neurology, and he is one of the prolific and very clever physician scientists coming from Johns Hopkins University, where he is faculty of neurology, ENT, and computer science. Um, and also allow me to welcome Dr. Qadeer Arshad, who is a lecturer in neuroscience, psychology, and behavior from University of Leicester. We are going to speak on a vestibular perception in migraine, and Amir and Qadeer, stage is yours.
Thank you, Asif. I'm going to share my screen and hopefully it's going to work. Uh, so, are you able to see my slides?
Yes.
Oh, great, thank
It's
you.
a blank blue thing. Now I can see something. It's very blurred though.
Well, so let me know if there's a problem because
It's clear here.
okay.
Oh, it's clear on your side?
Clear here too.
Yes, it is clear.
Okay, it's just then it's probably me. Okay, go ahead.
Well, thank you, Asif. It's a pleasure to be here. And as you can see, this is going to be a joint talk with Qadeer Arshad. And I'm going to start with what we mostly know about vestibular migraine, which is actually its diagnostic criteria. If we look at these criteria, they have actually taken shape as a diagnostic entity that now affects up to 1% of the general population and has become one of the most common cause of dizziness in modern clinical practice. This is great because a lack of universal definition of vestibular migraine can hamper patient identification in both clinical and research settings. But for those of us who consult patients with vestibular migraine frequently, we can see that these criteria do not cover many patients who have dizziness and migraine features that do not frequently occur together. So this brings us to a major gap in understanding mechanism of dizziness in vestibular migraine, as the diagnostic criteria are mainly based on the subjective quality of symptoms, and we have actually no objective measure of vestibular symptoms in these patients. So here, our goal is to go over some of our work related to perceptual measurement in patients with vestibular migraine. In the first half, I'll talk about spatial orientation and related sensory contribution, and how a simple head tilt can be used to study perceptual processes related to dizziness in these patients. And then Qadeer is going to touch on other perceptual aspects in these patients, including spatial attention, motion tolerance, and motion perception. So hopefully through this talk, we can highlight the need to apply these perceptual measurements towards better understanding dizziness and developing biomarker for diagnosis in patients with vestibular migraine. So if you look at clinical research into dizziness over years, it has mainly focused on the low-level vestibulo-ocular functions within the labyrinth or the brainstem. And we have paid little attention to perceptual functions of the brain, like spatial orientation, and how higher level structures like the cerebral cortex contribute to these processes and interact with lower brainstem structures, or how their dysfunctions can cause disabling vestibular symptoms in patients. So when it comes to vestibular migraine, what we know is mostly borrowed from general understanding of migraine pathophysiology. The trigeminal vascular system is thought to be the driving mechanism, and its activation and sensitization along with the nociceptive brainstem centers can cause headache. And related to this hyperactivity, abnormal sensory processing within the thalamocortical network can result in dizziness and spatial disorientation. And also altered activity at the lower level in the vestibular system could lead to transient vestibular ocular dysfunction or vestibular hypersensitivity in these patients. But what is the evidence for involvement of the thalamocortical network in vestibular migraine? This actually comes from few studies and each with few patients. In one study that compared ictal PET activity with inner ictal activity, found increased metabolism in the temporoparietal cortex and decreased metabolism in more posterior temporal parietal and occipital regions. Another study has found an overall decreased gray matter volume in the temporoparietal cortex, which is actually the area of convergence for multiple sensory modalities that contribute to spatial orientation, including vestibular, visual, and somatosensory inputs. But how about perceptual dysfunctions in vestibular migraine? Well, when we talk with patients with vestibular migraine, their clinical histories are full of experiences with the spatial misperception, which can range from increased sensitivity to either or both head motion and visual motion, sudden feelings of imbalance or tilt, and impaired concentration or fogginess, which can severely affect function at work or home. In clinical examination, however, many of them have normal vestibular ocular function, implying that their symptoms are due to high-level perceptual dysfunctions. Therefore, a simple and important question to ask about these patients is whether spatial orientation is affected by vestibular migraine. And if so, is that linked with their subjective complaints? But before we get there, let's look at normal sensory mechanisms that contribute to spatial orientation. Naturally, we maintain a stable perception of the world in upright orientation, even though we frequently change our eyes, head, and body positions, and for that, our brain must rely on multiple sensory input. Here's an example. When we get a camera and tilt it, in this case, in front of a painting by Mark Rothko, from side to side, the images move in the opposite direction of the movement of the camera. But we know that if we stand in front of the painting and tilt our head from side to side, the images stay steady. Well, you may say that in our case, the image remains stable on the retina because of the vestibular ocular reflex. This is actually the case for horizontal and vertical VOR, which are equal to the amount of head movement. But with changes in the head position with respect to gravity or with head tilt, it generates a VOR response that is a torsional eye movement in the opposite direction of the head tilt, which is known as the oculocounter roll. This oculocounter roll only partially compensates for the amount of head tilt. And as a result of that, there's going to be a change in the orientation of the images on the retina. Here's a helpful simulation that shows this change in the retinal image as a result of mismatch between the oculocounter and head tilt. So here, the left eye is shown in red, the right eye is shown in yellow, and you can follow the head trace in green. So with head tilt to the left, you can see the mismatch between the eye and head, and as a result, there is a change in the retinal image with both head tilts to the left and head tilts to the right. So this partial oculocounter roll may first seem counterproductive, but if we think about it, it can actually represent an advantage because it can provide the brain with pertinent cues to tease apart whether the source of the tilt is self or the environment. But the downside of it is that it is computationally costly for the brain to maintain spatial orientation. So if you look more closely, here's the challenge facing the brain to maintain a spatial orientation with changes in the head tilt positions. When we're upright, this won't be a difficult task because the head, eye, and the world, they're all aligned in vertical orientation. But when we tilt our head, because of the partial oculocanal rule, there's going to be a separation in the reference frames that encode the head and eye orientation. But we know that despite all these changes, we maintain a stable perception in the upright orientation, which shows that our brain, like any other sensory motor system, must be able to integrate these separate reference frames into a common sensory frame for coherent spatial orientation. But can we actually measure these sensory contributions to a spatial orientation? One way to measure that is by using gravity as a reference. And this is the basis for the subjective visual vertical or SVV task. In this task, the stimulus is a visual line and the subjects report perceived vertical orientation using the orientation of the line stimulus. The orienting visual cues are removed so that the brain has to rely on information about the head and body position in space and the eye position in the orbit in order to determine the orientation of the visual line stimulus and compare that to their perceived vertical orientation. This task has been actually studied for more than a century, and based on that, this graph sums up what we know about the inherent challenges the brain faces in maintaining spatial orientation, which is reflected by systematic SVV biases at different head tilt angles. In upright orientation, where the head is where the head axis is aligned with the true vertical, there is no significant bias. What with the small head tilts less than 60 degrees, the SVV bias is often in the opposite direction of the head tilt, which is known as the E effect. With larger head tilts, the SVV bias is usually in the direction of the head tilt, which is known as the A effect. So E effect, the head tilts in the opposite direction of the head tilt, and A effect, errors in the direction of the head tilt. So the mechanism behind these systematic biases in spatial orientation are also studied extensively, which have led into this effective framework that can explain biases of a spatial orientation based on how the brain senses the head and eye positions. The sensory input in this model are the signals that encode head position, and the head tilt results in oculocanal roll, which is encoded by the eye and head positions, and we also have visual inputs. And all these inputs go into the central neural processing, and the output is the SVV at different head tilt angles. We don't need to get to the details of this model, but the relevant point from this framework is that the signals that encode head position and eye position are noisy, and they need further processing to generate reliable estimates of eye and head position. The spatial orientation is then determined by the brain based on these sensory estimates that together give the brain eye and space estimate, and then when they're combined with visual inputs, they give the line and space estimate, and based on that, the brain can generate spatial orientation and report back the SVV. As part of this central neural processing, the underestimation of the eye position at a small tilt angle is the result of, it can lead to the SVV errors in the opposite direction of the head tilt or E effect, and the underestimation of the head positions at larger angles can lead to the A effect. And here is a simple view of this framework, and the SVV error is determined by the difference of the actual head and eye position and their corresponding neural estimates. Look, for example, with 20-degree head to the left and 5-degree of oculocanal roll to the right, the head estimates of about 22 degrees and the eye estimate of about 4 degrees will give us SVV of 3 degrees to the right, or E effect. And the same can be applied for other tilt positions. So knowing the normal pattern of spatial orientation during head tilt and having a framework to study that can be addressed whether patients with vestibular migraine have abnormal spatial orientation during head tilt. And that's when the brain is challenged to maintain the common reference frame for spatial orientation. We have designed a paradigm that can measure SVV based on what is known as a forced choice task. In this task, a random line orientation is shown and the subject has to report whether it is tilted to the right or left of what they perceive as vertical orientation. And here's an example of back-to-back trials and fast forward. The line is showing up in random orientation. Here you can see the range in which the line is presented randomly in gray. So based on this method, the SVB is measured by first plotting percentage of reporting right or left responses at different angles, and then fitting a psychometric curve into these responses. And SVB value would then be the point on the curve with 50% chance of reporting right or left responses. And here's the result. This graph shows SVB errors in patients with vestibular migraine in red compared with healthy controls, which are in blue. The SVB was measured in upright positions and with head tilts of 20 degrees to each side. And patients with vestibular migraine showed no significant error in upright position, but there was a larger error in spatial orientation to the left with head tilt to the right, which means that they showed larger E effect. And this error is about, as you can see, is about 4 degrees. And so just so we can get a sense, the Tower of Pisa is tilted about 4 degrees. So this is indeed a significant perceptual error. When we probed the patients about their symptoms, about 75% of them reported rightward symptoms in this group, like a sense of pulling or tilting to the right side, which is in line with their larger error with head tilt to the right. And as I showed you earlier, we have this framework that we can apply in patients with vestibular migraine to study sensory contributions to the errors of spatial orientation compared with controls. So based on this framework, we have the actual head position. We can measure ocular candle roll using video oculography, and we also measure SVB directly. So the other two sensory parameters here are eye and head estimates. If we can measure head estimates in these patients, the eye estimate can be derived from the other parameters in this framework. So one way to measure head tilt perception is to use a visual task similar to SVB. So in this task would be to align the visual line with the perceived head tilt positions, but there is a problem with that because of the partial ocular candle roll and mismatch between the eye and head position. If we use the visual task, it would give us the eye position in the space and not the head tilt perception. Therefore, a better way to measure head tilt perception is a task that is independent of the vision, and that would be a haptic task. And that's why we have developed a haptic task in which subjects have to touch a bar and report their orientation report their head orientation with respect to the orientation of the bar. So similar task to SVB, except that the subjects are touching a bar in a dark room and reporting back the orientation of the bar with respect to perceived head tilt position. And using this approach, we have started measuring head and eye estimates in patients with vestibular migraine and control. And this is a preliminary data from few patients with 20-degree head tilt to the right compared to controls. So the positive values here show tilt to the right and the negative values show tilt to the left. And you can see that there is a larger SVV error to the left in patients, but no difference in ocular candle roll compared with controls. When we measured head estimates using our haptic tags, there was a larger head estimates in patients compared with control, but the eye estimate was not different. So these findings suggest that overestimation of the head position could be the source of larger errors of spatial orientations in patients with vestibular migraine. This is actually in line with an earlier study in vestibular migraine from Lewis and his colleagues, Rick Lewis and his colleagues. They found that patients with vestibular migraine had lower threshold for motion detection in the role plane at lower frequencies compared with patients with other types of migraine or healthy controls. So in other words, patients with vestibular migraine had higher sensitivity to motion with lateral tilts, which is in line with the finding of higher head tilt estimates in these patients that we found. So this abnormal pattern of spatial orientation is also present with visual stimulation. Qadeer and his colleagues have actually looked into this using their visual dependency paradigm, in which SVV is measured in the presence of background visual motion in clockwise or counterclockwise directions. So they found that patients with vestibular migraine showed larger visual induced errors compared with controls, again suggesting altered sensory relating for spatial orientation in these patients. So this actually brings us to a timely segue to get to the Qadeer's portion of the talk. But before we get there, I just want to give you a quick summary of what I have discussed so far. So a major gap is that currently vestibular migraine is only a clinical diagnosis, and there is a lack of objective measures that can hamper efforts towards understanding its pathophysiology. I showed you some evidence that a simple head tilt can be used to study sensory contributions to spatial orientation and their association with symptoms in patients with vestibular migraine. And our preliminary findings suggest errors of spatial orientation in patients with vestibular migraine are related to higher perceptual estimates of head positions in these patients. So I'm going to stop here by thanking all the people who contributed to this work in our lab. And I guess it's better to take questions or comments after we both finish. So Qadeer, if you're here, you can, I'm going to stop sharing so you can take over.
Okay, great. Thanks, Amir. So that was fairly seamless, and there was always a worry that it wouldn't be. So thank you, Amir. So I'm going to carry on the talk by focusing on three areas, or two principal areas, and that is motion perception and spatial attention. So as aforementioned by Amir, a common complaint of patients with vestibular migraine is hypersensitivity to motion stimuli. So what does that actually mean? So in your clinical practice, you may often get patients coming in reporting such things that head turns make them dizzy, or lots of visual motion. So for example, when they go to the supermarket or when they go to a busy train station and there's lots of things happening visually, that they get dizzy. And another common complaint that you might find in some of these patients is that they report that now when they go in the car and they go around a roundabout and they're traveling, that they get more motion sick than they used to. So to investigate some of these perceptual problems in vestibular migraineurs, we proceeded to assess motion tolerance in vestibular migraine. We wanted to also assess sensitivity in detection of self-motion and look at the effect that visual motion adaptation has upon self-motion detection. And given that self-motion detection is cortically mediated and that areas in the brain that deal with balance signals are closely related to areas in the brain that allocate spatial attention, we wanted to see whether there was a dysfunctional attentional network in patients with vestibular migraine. So we started off by looking at motion tolerance in vestibular migraine. So we used a paradigm known as OVA, off vertical axis rotation. So subjects are rotated, not around their vertical axis as denoted here, but are tilted by 18 degrees off the Earth vertical axis and now are rotated around this axis. So subjects were rotated in the light at a velocity of 72 degrees per second, which generated a frequency of around 0.2 hertz. And that is a frequency that is known to be nauseogenic. And what we essentially did was we asked subjects to provide sickness ratings through every minute through 20 minutes of rotation. And the sickness rating had a 4-point scale, 1, 2, 3, 4. And 1 indicated that they had no symptoms, 2 indicated that they started to develop initial symptoms such as stomach awareness, but no nausea. 3 is that they started to develop mild nausea, and 4 indicating that they developed moderate nausea. If the participant reached a state of moderate nausea, 4, the chair was stopped at that point. But if they did not reach a scale of 4, then the chair continued until 20 minutes, at which point the chair was stopped. At that point, we also charted the recovery back to normal and measured how long that took. So as you can see in controls, here is the scale for mild nausea to evolve. And you can see that on average in healthy controls, it took around 6 minutes for the nausea to start to take place and for the participants to report. And as you can see, as expected, in the patients with bilateral vestibular failure, that they did not essentially develop mild nausea even after 20 minutes of rotation, so indicating significant amount of resistance to the evolution of motion sickness symptoms. But this resistance to motion sickness was not conferred by unilateral loss caused by vestibular neuritis, so they got a little bit more sicker than controls. But when you look at the vestibular migraine group here and the migraine in the dashed black lines over here, you can see that they developed mild nausea after only 1 minute of rotation. So you can see that they are poorly tolerant to motion and extremely susceptible to developing motion sickness. And if we look at the recovery, we can see that the bilateral vestibular failure patients recover the quickest, but the migraine and the vestibular migraine patients took longer to recover, on average around 15 to 20 minutes to start to recover back to baseline levels. And that's despite the fact that the vestibular migraine and migraine patients were rotating for a shorter duration compared to the bilateral vestibular failure patients. So we went on then to see looking at the sensitivity to motion using a paradigm called vestibular thresholds. So here we have subjects sat in a rotating chair, vibration free, and we can measure the vestibular ocular thresholds and the vestibular perceptual thresholds. So we used EOG to record the eye movements. So, and that is the onset of the nystagmus in response to rotation, and push buttons of a self-report that now I am moving to the right or now I am moving to the left. So here, for example, we have a chair acceleration below the threshold of the vestibular system to the left. So the acceleration profile was 0.3 degrees per second squared every 3 seconds. And as you can see, in response to a leftward rotation, the eyes start to move to the right. Here's the nystagmus onset. So we looked at the time from the chair onset to the nystagmus onset and took that as the vestibular ocular threshold. We also had the vestibular perceptual threshold, which is from the chair onset time to when they press the button that they were indicated that they're going left. And that measure, that time elapsed there, is the vestibular perceptual threshold. So this is the paradigm essentially. So here the subjects were sat in the chair, and we did 3 rotations to the right and 3 rotations to the left. And we took those as the baseline thresholds before we gave visual motion adaptation. We gave then 5 minutes of visual motion adaptation. So this was rightward visual motion using full field optokinetic stimulation at 40 degrees per second. And at the end of that, we turned on the light so the subject orientated themselves, and we reassessed the vestibular thresholds, just like that baseline, 3 to the right and 3 to the left, to look at the adapted thresholds. Okay, so here are the results. So sorry about that, I don't know, it froze. Here are the results for the vestibular ocular thresholds. So we recruited, on the x-axis, we have the 4 different patient groups. So we had the healthy controls and we had the vestibular migraine. And to control for the migraine bit of the vestibular migraine, we recruited patients with episodic migraine. And to control for the dizzy part of the vestibular migraine patients, we recruited patients with episodic vertigo due to benign positional paroxysmal vertigo. In the white boxes, we represent the vestibular ocular thresholds before the 5 minutes of visual motion adaptation, and in the gray boxes, after the 5 minutes of visual motion adaptation. On the y-axis, we represent the vestibular ocular thresholds. On the left-hand side in degrees per second as a unit, on the right in seconds. And as you can see, in healthy controls and migraineurs, there was no difference in the baseline thresholds. But in both BPPV patients and vestibular migraine, these were elevated compared to the healthy controls and the migraines. When we look after visual motion adaptation, in neither the BPV group or the healthy controls or the migraine was there any difference in after the visual motion adaptation. But you can see here in vestibular migraine, there was an elevation in vestibular ocular thresholds after the visual motion adaptation. Now looking at the perceptual results. So again, here we have the different groups on the x-axis and the actual thresholds in degrees per second on the y-axis on the left side and in seconds on the right. And again, pre-adaptive perceptual thresholds in white and the post-adapted in the gray. And as you can see, again, at baseline in both BPV and vestibular migraine, these thresholds were elevated compared to migraine and healthy controls. But after visual motion adaptation, none of the groups changed, such as BPV, healthy controls, and migraine. But notably in the vestibular migraine, we saw a significant enhancement in the perceptual threshold, almost 3 times higher. So it took them much longer to detect that they were moving. So this raises some interesting points. This shows that both vestibular ocular and vestibular perceptual thresholds at baseline are raised in patients with either BPPV or vestibular migraine, implying that there's a lot that is sensory noise that we equated to some sort of vestibular tinnitus that makes it difficult to detect motion. But after visual motion adaptation, they become significantly more prolonged only in the vestibular migraine group, suggesting that there's some sort of abnormal visual vestibular cortical interactions in the vestibular migraine population. But if we link this back to what Amir was talking about regarding spatial orientation, the fact that these patients are now finding it increasingly difficult to tell which direction they are moving, it takes them much longer to figure out whether they're moving to the right or moving to the left, it would imply that they are somewhat disorientated. So how do we link this abnormal self-motion perception back to spatial disorientation? So what we looked at was the error rate. So there was 12 trials in total, 6 before adaptation and 6 after. And we looked at the error rate. So that is, across those 12 trials, how many times did the subjects indicate the wrong direction? So that is, they were moving to the right, but they indicated that they were moving to the left. And so we calculated that as a percentage. And here on the x-axis, we have the different groups. And you can see that in the migraine healthy controls and the BPV, the percentage error was relatively stable at around 5%, but it was almost 3 times higher in the vestibular migraine group at around 15%, indicating that this abnormal self-motion perception in the vestibular migraineurs was causing increased error rate, indicating that these patients were spatially disorientated. So having established this, and given that spatial attention is key to orientate yourself in space, we proceeded to investigate the effect, whether vestibular migraineurs have abnormal allocation of spatial attention. So we used a task called the Posner task. And in this task, you are given some sort of cue or no cue. So here there's no cue. Here there's a cue that something is about to happen. Here's a double cue, something is really about to happen. And this is a spatial cue that something is about to appear in the opposite hemisphere. So up here, or in this example, down here. And what you have to do is shown here in B, is you have to respond to the central arrow using a keyboard. So here the target arrow is pointing to the right, so you have to press right. Here the target arrow is pointing to the left, so you have to press left. And this is a neutral condition because the flankers, these bits on the side, are not giving any information. Here in the congruent, this is because the target arrow is flanked by arrows that are given the same information so as the target. So this is congruent. And here it's pointing to the left, and these flankers are also pointing to the left. And in the incongruent, this is where you have some distracting information. So here the target arrow is pointing to the right, and the flankers are pointing now in the opposite direction to the left. So you have to ignore the flankers and point to the target arrow. This is the incongruent. And the general effect is that the incongruent is the hardest. So the reaction time to respond to this target arrow here is the longest. And here in the congruent, this is the easiest because the flankers provide additional cues. And this is somewhere in the middle. And with respect to here, the spatial cue provides the fastest reaction time. And as you might expect, the no cue provides the longest reaction time. So here we're looking overall globally at the attentional system in patients. And we're looking at the evidence drawn from the stimulus type. So here, look, we're comparing the trials with neutral, congruent, and incongruent. And as you can see, as I just mentioned, that the incongruent reaction times as a group were slower than the congruent, which were the fastest, and the neutral lied in the middle. So here we have the reaction times, and here we have the different stimulus type, neutral, congruent, incongruent. In the white box, we represent healthy controls. In the gray, episodic migraine. In the shaded area, we have peripheral vestibular, and in the black boxes, we have vestibular migraine. And as you can see, in all three, the neutral condition, the congruent, and the incongruent, there were statistical significant differences between the healthy controls and both peripheral vestibular disorder patients and vestibular migraine across the board. And so what this indicates is that patients with vestibular dysfunction, be that peripheral vestibular dysfunction or central via vestibular migraine, it caused a slowing in the reaction time for the neutral, congruent, and incongruent stimuli. Here we have the cue type. So again, as I said, the no cue is his reaction time. The no cue has the longest reaction time, and the spatial cue has the shortest reaction time. You can see that. But again, in all of the cue types, we observe significant difference between the controls and the peripheral vestibular patients and the central vestibular migraine patients. So again, irrespective of the cue type, patients with vestibular dysfunction were slower than controls. So these findings imply that there's some sort of generalized attentional dysfunction in patients with vestibular disorders. But we wanted to see whether we could find any specific deficit in these patients. So you can look at domain-specific networks. So we can look at, for example, the alerting network. And so this takes the reaction times for the trials with no cue, and it takes the reaction times for when you have a massive alerting stimulus, a double cue. And you can get a derived reaction time represented here. And here we have the different groups, the controls, the episodic migraine, the peripheral vestibular disorders, and the vestibular migraine. And as you can see across the board, there was no difference. So there's no difference in the alerting network. Then we looked at the orientating network, which looked at the central cue minus the spatial cue. And here we have the derived reaction time. And across the board, although there was a variability across the four different groups, there was no statistical difference between any of these. And then finally, we looked at the third network, which was the executive control network, which takes the reaction times for the incongruent, where you have to ignore the peripheral distracting information of these incongruently placed arrows, minus the congruent reaction times. And here we have the derived reaction time in milliseconds. Here we have controls, the episodic migraine, the peripheral vestibular and vestibular migraine. And here we observe a significant difference between the healthy controls and the vestibular migraine. So the vestibular migraine showed a deficit in the executive control network. And this is important because this network is suggested to be important to resolve conflict and to ignore peripheral information that is distracted. And if we link this back to the patient's complaints, they are often troubled by information that is irrelevant and peripheral. So for example, as they're walking down the supermarket aisle, things spatially placed in the periphery up above on the shelves are not important, but they seem to be largely troubled by those type of stimuli. And so it could be that those type of symptoms are due to some sort of executive control dysfunction with the attentional network in these patients. So to conclude, together, we hope that we've demonstrated that vestibular migraine, or have provided some sort of evidence to convince you that vestibular migraine patients have various perceptual abnormalities, such as Amir demonstrated, the inability to accurately detect head position in space, and also they have altered motion perception. We've shown that they have some sort of skewed or abnormal visual vestibular interactions. But the commonality throughout this talk is that what the deficits that Amir has described and that I have described, they seem to culminate in a certain degree of spatial disorientation, which is a key feature that the patients can present with. So our future work, independently and together, is to establish the neural correlates of spatial disorientation in vestibular migraine patients, with the ultimate aim of targeting these areas with novel diagnostic techniques to reduce symptom burden in vestibular migraine. And just finally, before I finish, much of this work was done before I'd moved to Leicester, and I worked and collaborated for a long time with Professor Rodolfo Bronstein, and so I'd like to thank him and the whole of the neurotology group for all the various students and fellows that I worked together with there in producing this body of work that I have presented to you today. Okay, thank you.
Thank you, Qadeer. Thank you, Amir. So let's see, there is a question. It says your microphone was turned off. Never mind. So let's see, there are other questions because I have a question. Jorge, you have a question?
Yeah, I just took to clarify the BPPV patients were posterior canal BPPV when symptomatic or were in remission?
Okay, so very good question. So the BPV patients were all posterior canal BPV, from what I recall. Yes, and but this is the key point. So what we did is they presented to clinic, and we performed the first treatment, the first epi treatment at that point. So they came into clinic, they had the whole bike, confirmed it was positive posterior canal. We treated it, and then after an hour later, we tested. So if we were good at treating, then they were asymptomatic. But if we are not, then there was...
Great work. Thank you. Do you have a subset of BPPV patients with migraine?
So we made sure that they do not have migraine. And this is a problem because Rodolfo Bronstein published a paper a little while ago looking at visual dependency in a group of BPV with a negative Hall-Pike. And the question was whether those individuals had essentially positional vertigo, which was a form of vestibular migraine. So we were very careful to make sure that they had no history of migraine, these BPVs, and that they had typical posterior canal BPV. But as with anything, we try to exclude it to the best of the ability, but maybe one or two sneaked in.
And the last question that I have is it possible that because they also have increased motion, lower motion sickness thresholds, that the velocity storage could be another cofactor? So you have increased head motion, the detection that all the experiments that you did, and then perhaps heightened velocity storage.
Yes. So I mean, the role of the velocity storage mechanism in vestibular migraine patients is not well known. I mean, I remember some study in the past that showed that they have a prolonged response. If you look at the time constant of the decay of the oculomotor response in response to chair rotation, velocity step rotations, indicating that there's some sort of abnormal function in the velocity store. But we need to look at that. And one of the areas of research that we're going to specifically look at is to probe the velocity storage function in these patients in more detail.
Thank you.
So since we have a little time, I have a few questions, but before that, somebody else asked this question. I think he's from India. The question is pretty generic, which is like more of didactic, I think. So what is the best prophylactic treatment for vestibular migraine?
Amir can answer this one.
Amir can answer it. We can all pitch in.
Well,
Go ahead, Amir.
Well, I think the answer to that, the short answer is we don't know. There have been some clinical trials on different medications, and none of them have shown that there is a single medication that can really provide relief or prophylactically help with these patients significantly than others. But what I try usually in my practice is I usually use the old TCA medications like amitriptyline. I always start with a low dose, and the reason I choose that because it has more like a broad effect. And what I have noticed is that these patients actually respond better to combination of approaches that can really help patients to train their spatial orientation skills along with the medication. So medication by itself is not that effective. So it's a combined approach of vestibular physical therapy or balance exercises that can help patients to train their perception of spatial orientation can be more effective in treating the patients with vestibular migraine.
Yeah, I agree. I mean, nortriptyline, amitriptyline is my first choice also, and my first choice because John Lee told me it was his first choice too. I think he used to use that a lot, so that's how I learned doing it. But it works quite well for me also. Of course, some very old people and who don't tolerate TCAs, I sometimes, or if they have like hypertension or other indications, I go for propranolol. I mean, traditional things that you do for any migraine, you could use that. Speaking of which, I wonder, how do you factor in botulinum toxin for vestibular migraine? Because I know some of our colleagues use it for vestibular migraine, and I wonder whether it has anything to do with, so as you inject migraine Botox, you not only just inject on the forehead, but you also inject on the back, right? Some by the insertion of the neck muscles. And I wonder whether by doing that, you are changing the proprioceptive signal that goes to your head on space or head on trunk plant. You know, in your Bayesian model, you had that little box that goes up to eye in orbit. I wonder, it'll be interesting to do the study that you did with maybe vibration, like you change the neck proprioception transiently with like a little vibrator in the neck, or and people who get Botox for migraine.
That's a great point. I don't know anything about the effect of Botox on dizziness, but it is a treatment for headache for sure. That a lot of
I mean, people use it all the times for headache.
Right.
I mean, I don't really have any patients who I inject for migraines because of logistics. So most of my my patients are dystonias, but I know that some people use Botox for migraine, and they also have vestibular migraine in their mind. So it's just curious.
You know, as if anecdotically, I can tell you that I had a good experience with patients with vestibular migraine. When you control the headache, for some reason, excuse me, for some reason they improve the vertigo also.
Yeah.
I had at least, I don't know, 9 on 10 patients in this situation. Obviously, we inject because headache, but they improve the symptoms also.
Yeah, and probably that makes a lot of sense because, I mean, a lot of times we do that, right? We make Parkinson patients sleep better so that their day is better. You know, I mean, their tremor is better. Sleep has nothing to do with day tremor. Another interesting thing, sorry, go ahead, yes. Michael. Oh, sorry, Sergio.
Yes, the new monoclonal antibodies are used headache and vertigo. We had a limited experience, but it had a lot of sense, you know, and it's a very convenient treatment to use because it's once per month, no side effects at all. We had in Argentina Enersumab, and another ones are coming. So probably will be a promising treatment in the near future.
Yeah, it is up and coming. A lot of, in fact, I moved some yesterday from our freezer. It broke. So that's what I was doing in between, like our freezer broke. Anyways, one more question since we have a little time. So Qadeer, you showed this this little graph where you had like a vestibular neuritis, and then you had migraineurs, then you had this bilateral vestibular dysfunction, which was quite shallow slope, right? Do we know that if somebody who is avid migrainer, I'm saying avid migrainer, right? If somebody's avid migrainer and unfortunately that person gets gentamicin or something and that gets bilateral hypofunction, does the migraine, vestibular migraine, go away?
Does the vestibular migraine go away, or does the motion sickness go away?
Or motion sickness, I mean.
Yeah, the motion sickness. Okay, so we don't know. We don't know. And but you would expect that the vestibular system is key to develop the evolution of motion sickness.
Mm-hmm.
So
yeah.
If you were to and so we did a study where we downregulated by applying electrical stimulation to the vestibular cortex in healthy individuals to suppress the vestibular signals coming from the ear during OVA. And what we found was that was highly effective in suppressing motion sickness. So if we extrapolate from the healthy individuals and extrapolate that into patients, if you are a migrainer who is normal vestibular function and you get very motion sick, if you were to lose the thing that causes you to be motion sick, the vestibular signals, then one would expect that you would continue with your migraines and you would not get as motion sick as you used to.
I'm just curious, maybe Brian can tell us the answer. Can we downregulate vestibular end organ with magnetic stimulation? Like create a lesion, so to speak?
Yeah, it's a good question. I think we haven't really explored that all that much yet. But yeah, fascinating to think about the implications of magnetic vestibular stimulation, and you'll get more of that in a little bit, I think.
Yeah, and then they can sit in the airplane with a little magnet and then they're fine. Okay.
A very strong magnet that they wouldn't let on the airplane.
I know, I'm just messing. Okay, great.